This video is going to be on pathology of the uterus and of the cervix. So just to recap the anatomy of the cervix and the uterus, here's your uterus, and then on the lower portion, you have your cervix that connects to the vagina. And the part of the cervix facing the uterus is called your endocervix. And the part facing the vagina is your ectocervix. Your ectocervix is squamous epithelium. Your endocervix is columnar. And that area where they meet and change is called your transformation zone. And that transformation zone is dynamic. It grows constantly. There's a high turnover rate. For example, if the uterus grows during puberty or pregnancy, then the transformational zone also grows with it. Okay, so the transformational zone isn't static, it can move around. That is the general anatomy of your uterus and your cervix. We're going to start talking about pathology, and we can't talk about pathology of the cervix without talking about HPV. Now, if you're from my alma mater, you know a lot about HPV. That doesn't sound right. Unless you're from Santa Barbara, then that sounds exactly right. What I mean is, if you're from my medical school alma mater, then you know a lot about HPV because we have a local celebrity there that came up with the HPV vaccine, Gardasil. HPV is very important because it is the most common STD. HPV, most common STD, which sounds scary. However, we clear it usually. Our immune system is good with clearing HPV. Sometimes HPV isn't cleared, and if you leave HPV to persist, then it can cause cellular change. HPV is a virus. It loves places with high turnover rates, like your transformational zone. It likes those because cells are always dividing, and it likes that. You know, it's a virus. It wants to infect more cells. Not only does it like high turnover zones, but it also can produce high turnover rates of cell by producing proteins that disrupt the cell cycle. These proteins are things like protein E6 and E7. E6 disrupts P53. E7 disrupts retinoblastoma proteins. That's a nasty virus. It can actually disrupt your tumor suppressor proteins, and from doing that, it causes your cells to rev up, to replicate, and it can infect those cells. That's why it does that. That's the purpose of the virus doing that. But because it revs those cells up, there's more chances for mutation. There's more chances for those cells to mutate and to show dysmorphic changes. Do you remember what we call dysmorphic changes of cells due to HPV? We call that coilocytic changes, and you need to be able to recognize that, those coilocytic changes on an image. Now, low risk strains like type 611, they still cause those cells to mutate, but those cells will mutate and form warts or condylomas. High risk types such as 16, 18, 31, 33, and there are a lot more which will be in my notes. These cause cells to undergo dysplasia, which can ultimately become neoplasia, and the most feared of all is cancer. Can we prevent HPV infections? We can vaccinate. Most common being Gardasil, and that protects against types 6, 11, 16, and 18. But I think the biggest contribution to lowering rates of cervical cancer from HPV would be your Pap smear. We started at age 21 for gals, and we put a spatula in, or a brush, or what have you, into the transformation zone. Scrape off some cells and look for coilocytic change. We're trying to catch changes before they turn into cancer. We're trying to catch dysplasia. And that Pap smear has basically sent cervical cancer rates plummeting, which is great for us. Now here's the question. If you get If you give someone Gardasil, do you still need Pap Smear? The answer is yes. It protects against these high-risk strains, but there are still others. Still cases of cervical cancer every year. Try as we might, sometimes we miss cervical cancer. Sometimes we miss dysplasia and picking it up early, and a patient can develop cervical cancer. Now, cervical cancer presents with bleeding, also presents with post-coital bleeding. That's usually more common, just from the anatomy standpoint of it. The risks include high strain HPV infections, and I guess you can say more chances of HPV exposure. So having sex early in your years, or multiple partners, things like that. You can also have risk from smoking, because why not? Smoking is always a risk for everything. Immunodeficiency. Why is that? We said that you usually can clear HPV, your body's immune system can clear it. If you're immunodeficient, you can't do that. So HPV persists, causes those changes, causes dysplasia, ultimately cancer. We start Pap Smear screening at 21, like I said. However, an immunodeficient patient, we might start earlier because they can't clear the strains. So no, immunodeficiency is a big one. If they ask you what's the biggest risk factor for cervical cancer in a normal patient, it'd be things like HPV infection, multiple partners, etc. If they ask what's the biggest risk factor in an immunodeficient person, it is immunodeficiency. Not this, okay? It's immunodeficiency. That's the main problem. They can't clear the bug. Another fact you should know about cervical cancer is that 80% of it is squamous cell carcinoma. About 20% is adeno. You get very rare types like clear cell. What's associated with clear cell? DESUs. But the most important and the most common is SCC and adeno. Adeno, unfortunately, doesn't show up well on PAPs. That is a very important thing you should know. Pap smears don't pick up adenocarcinoma the same way they pick up SCC. Okay? Very important that you know that. Cervical cancer, the complications of which they can invade your anterior wall, and in your anterior wall is your bladder and your ureters. So they can invade that, let's just say urinary system, and cause hydronephrosis. Where you can't drain your urine, your ureters dilate, your kidneys get damaged, you get renal failure. And that is actually one of the most common ways to die from cervical cancer, not to cancer outright, but through hydronephrosis, renal failure. That is pathology of the cervix. You can see it's very HPV heavy. It circles around HPV. You should definitely know things like Pap smear, things like the strains of HPV, how it causes change through the proteins E6, E7. Definitely know them cold. All right, that's cervical pathology. Let's move on to uterus pathology. Let's go into a little bit more in-depth anatomy of the uterus. Your uterus has linings. The inside lining is your endometrium. That is your functional layer. That is what grows during your cycle. That is where the baby implants. So is your functional layer. And how does it grow and shed and implant? It is sensitive to hormones. Hormones tell it whether to grow or to shed, etc. Hormones. For the sake of this video, the main one you need to know is that estrogen causes growth of your endometrium. So that's your inside layer. Your layer right beneath it is your myometrium. name should give it away, myo. It is your muscular layer, smooth muscles, smooth. Main function is to contract. So contractions, labor, etc. Outside layer is your perimetrium. There's not too much to know about that other than it's your outside layer. Most of the pathology that deals with the uterus will deal with the endometrium. Some will deal with the myometrium. We'll just knock that out first. So your myometrium, you can have pathology such as tumors of your myometrium. That is called leiomyosarcomas. Myomas. More commonly just referred to as fibroids. Fibroids are leiomyomas are fibroids. Very, very common. You'll just see these growths. These very smooth, well-demarcated growths causing an irregular uterus. There can be multiple growths, pretty uniform, multiple uniform, and if you cut them in cross-section or you see a histoimage of it, it's a whorled pattern. While it's a benign tumor, it can cause a lot of, pressure. It can cause dysmenorrhea, menorrhagia, cycle problems. Ultimately, they can grow very, very large. They're also sensitive to hormones, so they can grow during pregnancy, they can regress during menopause, and they can cause problems that way. So leiomyomas, very common. Know just the basic features of it, and know that sometimes it can transform into a malignant form called lyiomyosarcoma. The sarcoma denotes that as malignant. Very, very rare, but it can do that. Most of leiomyosarcomas are spontaneous, so they're not from malignant transformation. How can you tell the two apart? Well, when it becomes a sarcoma, it's going to lose its whorled appearance. It's going to lose whorled appearance. Instead, it's going to appear necrotic, hemorrhagic, just looks worse. So necrosis. And also, whereas leiomyomas, fibroids, oftentimes there are multiple discrete tumors. These can be single, irregular, hemorrhagic, necrosis, gross looking. Those are your leiomyosarcomas. I think that's all I want to talk about on the myometrium. Let's get to the meat of this video. That is your endometrium, your functional layer. Your endometrium is very dynamic. Like I said, it can grow. And because it's dynamic, a lot of the pathology we'll talk about when we're talking about the endometrium is how it's growing or how it's invading or how it's places where it shouldn't be. All these different things due to its dynamic nature. But just because it has a dynamic nature doesn't mean it's not affected like the rest of your tissue. It can be inflamed. We call that endometritis. The itis is just inflammation, and endometritis is caused by when you have things on your endometrium when there shouldn't be. So foreign bodies, how does foreign bodies get into your endometrium? Well, these would be like your IUDs or retained products of conception. So any placental tissue or fetal tissue that's left after delivery, a miscarriage, ectopic, what have you. If it stays in there, it can cause infection, be like a breeding ground for bacteria, cause endometritis, okay? So if they talk about pelvic pain in the history of this, you're thinking endometritis. It can progress into chronic endometritis, and that's difficult to discern between that and PID. PID being far more common. So to discern it, you have to do a biopsy, and the biopsy will show plasma cells in your endometrium. So you know it's your endometrium that's actually causing the problem. You need that biopsy to make that diagnosis. You can't just say it's endometritis because PID is more common, and if you misdiagnose, you can lead into a bunch of complications, okay? That's just to show that it can be affected by, I guess, normal pathology. But what I really wanted to get into is how it can grow, invade, be where it shouldn't be. It's dynamic nature. So one of the things I want to talk about is something called adenomyosis. Adenomyosis is when your endometrium invades into your myometrium. So your endometrium will invade into your myometrium. And the biggest sign, the biggest clue in the questions I have gotten about adenomyosis is that your uterus is uniformly enlarged. Uniformly enlarged is the biggest key. As it grows into your myometrium, your endometrium is, of course, sensitive to hormone changes. So when you have your period, you might have disrupted period, you might have heavy bleeding, pain, but that's somewhat non-specific. The more specific sign, and the sign that helps give it away, is this uniformly enlarged uterus, okay? So know that well. Next is endometriosis. Extremely common. This is when you have endometrial glands and stroma where they shouldn't be. How does that happen? Well, there's a couple of theories on how that happens. One is called retrograde administration. So your endometrium sloughs off during menstruation, comes out through your vagina. Retrograde would mean instead it goes towards your fallopian tubes. And the endometrium contained in that outflow will implant and cause endometriosis. That's a theory. We call that retrograde menstruation. Other theories are that the endometrium or parts of the endometrium can be carried away by the lymphatics or vessels because it is very highly vascularized. So we'll just say carried away by blood or lymph. The last theory is metaplastic change or metaplasia. So that's cells turning into endometrial tissue. So this could be like an ovarian stem cell. Instead of becoming an ovarian cell, it becomes an endometrial cell. That would be metaplastic. Whatever the case may be, again, these are just theories. You have endometrial stroma and glands outside, and those can be on your ovaries. It's very common. It can be in your fallopian tubes, cause scarring, lead to infertility. Again, very common cause of infertility. But the biggest giveaway is cyclic pain. Your endometrium responds to hormones. And if it's implanted in your ovary, or it's implanted on your bladder, or it's implanted where have you, then during your cycle, it can grow and respond, and that causes cyclic pain. Always ask if they have pain in their cycle during urination or defecation. That's another more specific sign for endometriosis. They might not volunteer that information. Shout out to Goya. Volunteer that information, but if you ask, they might tell you, and that helps you make the diagnosis of endometriosis. How do you treat it? You can try conservative management, like NSAIDs. You can try and regulate the cycle or suppress the cycle so they don't have this pain through OCPs. That's very common. But if all else fails, then you can do surgery to remove those glands. So that's invasion. That's endometrium where it shouldn't be. We can just have endometrial growth. So endometrial growth. A lot of the time this is from increased estrogen. One of the most common is just a polyp. That's just a piece of endometrium that grows out. A lot of gals have this, usually asymptomatic. You just kind of see it incidentally. Or you can have endometrial hyperplasia. So estrogen is stimulating the endometrium to grow more than it should. And anytime you have hyperplasia, that should be a cause of concern. Anytime you have high cell turnover rate, because that can lead to dysplasia and lead to cancer, which is our last topic of this video. Endometrial cancer comes from two pathways. One is just growth from increased estrogen. Won't harp about that too much. You have too much estrogen, Whether it's from obesity, because adipocytes have aromatase, which aromatize androgens to estrogen, or whether they're taking hormone replacement therapy or what have you. Whatever the case, increased estrogen causes hyperplasia. Hyperplasia can lead to cancer. This is the most common. This pathway has the better prognosis. Suspect this in a patient who's postmenopausal and they're bleeding. That's not normal. Bleeding is from the estrogen making your endometrium grow and then sloughing off. So postmenopausal bleeding is a big red flag. The second pathway is your sporadic pathway. It's called sporadic because it comes out from nowhere. It doesn't need hyperplasia, it just arrives spontaneously. Associated with p53 mutations. I should write sporadic. This has a worse prognosis. Worse prognosis. Now you should be able to tell these two apart just by history. Estrogen pathway would have signs like obesity, or maybe they're taking estrogen drugs. And then sporadic would just be sporadic. They wouldn't have any of those risk factors. However, you should also be able to tell them apart by histo. So this pathway will show cancer that looks like the endometrium because it's from endometrial hyperplasia. So endometrioid. Sporadic, however, isn't from endometrial hyperplasia. Instead, it has projections, papillae, and more importantly, it has psammoma bodies. So sporadic has psammoma bodies. Endometrial hyperplasia pathway has endometrioid looking cancer. Okay? That does it for this video. See you next time.